The goal of the program is to prevent tooth decay and expedite referral to a dentist for children who need early intervention. This course will present information on determining caries risk, conducting an oral health assessment, providing anticipatory guidance to parents and caregivers, referring children who need care to dental professionals, and applying fluoride varnish to the teeth of children at risk for tooth decay. Pediatric dentists consider any signs of caries activity in a child under age 6 to be early childhood caries, or ECC. Any sign of smooth surface decay in a child younger than age 3 is defined as severe ECC. Early childhood caries can lead to extreme pain, infection, difficulty in chewing, poor weight gain, extensive and costly dental treatment, increased risk of dental decay in adult teeth, and crooked teeth. Tooth decay is a big problem. It's 5 times more common than asthma and 7 times more common than hay fever. Data collected from 1999 through 2002 show that 28% of U.S. children aged 2 through 5 had decay in their primary or baby teeth, and only 30% of those decayed surfaces had been filled. Why can't dentists take care of this problem? In Ohio, Medicaid-eligible children under age 3 don't get to the dentist. In 2003, more than 78% of very young children received at least one EP-SDT or health check visit, but only 3% received dental services. Young children see medical providers much sooner than they see dental providers. Let's look at the factors necessary for caries to occur. Tooth decay is a complex process involving the tooth, the oral flora or bacteria, and a substrate or food for the bacteria. The outer layer of the teeth, the enamel, is where the caries process begins. Whether teeth are susceptible to decay will depend on a person's age, their exposure to fluoride, the shape and position of the teeth, the patient's nutritional status, and whether there's acid present. The mouth contains billions of bacteria. They are site-specific and begin to colonize once the teeth begin to erupt. Tooth decay, or dental caries, is an infectious process that is initiated primarily by Streptococcus mutans. The decay process can proceed at varying rates depending on the substrate available in the mouth, a person's oral hygiene, and the presence or absence of fluoride. Dental plaque, a sticky film comprised of bacteria, mucus, and food particles, will promote the decay process as well. Many don't realize that bacteria are transmitted mainly from the mother or primary caregiver to the infant. If a mother's saliva contains significant numbers of decay-producing bacteria, and if she shares her saliva with her baby at an early age, for example by testing the warmth of the baby food or cleaning off the pacifier by sucking on it, there is a higher risk of caries for that child. Once infected with the bacteria, the caries process is promoted by carbohydrates which break down food to form acid. The acid demineralizes the enamel, causing it to soften and decay. Because saliva provides an important buffering effect, anything that affects salivary flow will impact the caries process. It's not just what the child eats, but how often he or she eats carbohydrates that will affect the potential for tooth decay. For 20 to 40 minutes after carbohydrate consumption, the pH or acid level of the mouth drops enough to reach the danger zone. Demineralization, or leaching of the minerals from the tooth enamel, occurs in the presence of acid. If an infant has a bottle at 6 a.m., breakfast an hour later, a mid-morning snack, and a sippy cup an hour or two before lunch, the tooth is repeatedly exposed to acid attacks. Parents and caregivers should be instructed to limit the amount and the frequency of sugar consumption. By the way, this anticipatory guidance is easy to include in any counseling provided about the problem of obesity in children. Breastfeeding is strongly recommended by the American Academy of Pediatrics and the American Academy of Pediatric Dentistry. Breast milk alone does not promote tooth decay, but if combined with other carbohydrate sources, it could increase a child's risk for early caries. If a mother and child choose to breastfeed on demand with high frequency and duration at night, it would be appropriate to emphasize the importance of oral hygiene following feedings and refer to a dentist for regular checkups. How does fluoride affect the caries process? It reduces enamel solubility and promotes remineralization of enamel. There is a constant tug of war going on at the tooth-plaque interface, which dental professionals call demon-reman. In the presence of acid, the tooth loses minerals. If fluoride is present in the dental plaque, it works topically to arrest or reverse early caries, remineralizing tooth enamel that is just beginning to soften with decay. Fluoride also inhibits bacterial growth, thus reducing acid production. A combination of fluoride vehicles, such as drinking fluoridated water, using fluoride toothpaste, and applying fluoride varnish, is encouraged for high-risk patients. It is important to determine whether a child is drinking fluoridated water. Most major Ohio cities are fluoridated. Consuming water that contains 1 part per million fluoride can reduce tooth decay by up to 40%. If a child's family has a private well, the fluoride level should be tested because groundwater can naturally contain trace or high amounts of fluoride. The Ohio Department of Health has information on fluoride levels in community water systems. The training manual contains information on how to contact the Ohio Department of Agriculture to have well water tested for fluoride. It costs about $18. If fluoride levels in a child's drinking water are below optimum, fluoride supplements can be prescribed according to the Dietary Fluoride Supplement Schedule developed by the Academy of Pediatrics, Pediatric Dentistry, and the American Dental Association. When deciding whether or not to prescribe a dietary fluoride supplement, consider that effectiveness requires a long-term commitment and considerable caregiver compliance. Consuming too much fluoride during the early years of tooth development will put a child at risk for dental fluorosis, a condition that ranges from white flecking of the enamel to dark stains and pits on the tooth surface. The most common reasons for mild to moderate enamel fluorosis are improper prescription of dietary fluoride supplements and ingestion of too much fluoridated toothpaste. Young children have immature swallowing reflexes. Therefore, it is recommended that children under age 2 not use fluoridated toothpaste. After age 2, only a small pea-sized amount should be applied to the child's brush. Once permanent teeth have mineralized, about age 6 to 8, the risk of enamel fluorosis is no longer a concern. In spite of widespread use of fluorides, dental disease is still a problem for some children. 14% of 3-year-old Medicaid patients in Ohio Head Start programs had early childhood caries. Let's